this child has pulmonary hypertension. What would you like to do? Do you want to repeat the echo by a pediatric cardiologist, or are you trying to disbelieve the echo? What is unusual in this echo finding? And if the same findings are there, what would you do? Would you decongest the patient and early the ASD closure? Wait for elective ASD closure by 2 to 4 years of age. ASD cannot be responsible, and therefore we are very worried and nothing can be done about this. Yeah, you would like to do an echo. Why do you want to do an echo? Yes, absolutely right. The very unusual situation in this is, why does this patient have pulmonary hypertension at the age of 6 months? The most important thing for you to do is disbelieve the echo and get it repeated. Are we missing something else in this? Why is this patient of atrial septal defect having pulmonary hypertension? Are we missing something? Like, for example, there are some defects which are easily missed if not looked by an expert. There are certain areas in the ventricular septum where you can miss ventricular septal defect. There is a condition called AP window, which is easily missed. So there are certain areas in the cardiac evaluation of an echo where you can miss certain things. So please don't believe this report first. Suppose I say that the report is correct. This patient has no other defect, has an atrial septal defect with severe pulmonary hypertension. Are you worried or are you not worried? We are extremely worried. Is this ASD responsible for pulmonary hypertension, or does this child has a combination of primary pulmonary hypertension, or rather non-regression of pulmonary artery pressures, and ASD is just an innocent bystander? That is a question which is extremely difficult to answer. There are really no tests for us to answer this question. Is this just a non-regression of pulmonary hypertension and ASD is an innocent bystander, or is the ASD actually responsible for causing the severe pulmonary hypertension? Either way, the prognosis is bad. But what we would definitely do is that, since we are finding a structural heart disease, we would presume that this atrial septal defect is probably responsible for pulmonary hypertension, and remember that it can close on its own if it is small. That is, if it is less than 8 millimeters, but you are seeing this child during infancy. An 8 millimeter defect seen at 5 years of age is not going to close. But an 8 millimeter defect, if is seen in infancy, there is 80% chance that it can close. So the first clinical scenario is something where we would like to wait and watch and allow nature to try to do this by itself. More than 8 millimeters will require elective closure of the defects. Ostium primum ASDs, sinus venosus ASDs will never close by itself, so they are destined to have surgical closure of these defects. And today, the recommendation is, let us wait for 2 years. If you look at the classic textbook recommendation, it says that let us wait till school-going age, 4 to 5 years. The reason that we have reduced this age cutoff is that today, operating on a patient of atrial septal defect almost carries 0% mortality. Literally in major institutions which are doing pediatric cardiac surgery. But, so why do you want to wait till 4 to 5 years? Let us take off the psychological impact of having to send a child at 4 to 5 years of age for surgical correction, when you know that there is no difference in morbidity or mortality if you do it at 2 years, provided you are sure that this atrial septal defect is not going to close. So that is the current policy for us as far as the atrial septal defect is concerned. If you, whenever you think that I have to stop, please let me know. We are going on to the third most common defect, and that is a patent ductus arteriosus. Here we have a 6-day-old child, 32-week preterm baby, tachycardic, tachypneic, ejection systolic murmur. The echo shows a large ventricular patent ductus arteriosus and a peak gradient of 20. Basically, it means that this child has pulmonary hypertension. What would you do? Will you do decongestive management, indomethacin oblique ibuprofen? If no response, send for surgical ligation. So, would that be your plan? Or would you wait and watch? Yeah, surely. This should be your plan. There is no point in waiting. I'm sorry. And if no response, surgical ligation. This is the classic treatment of patients, of premature babies with a patent ductus arteriosus. who are not responding to medical management. You would definitely, most of these patients are ventilator dependent. Try to give drug therapy for trying to close these patent ductus arteriosus. Even if it doesn't close, if it has reduced in size, that is something which is defined very well on echo. And you must be aware of the so-called functional echocardiography, which has become very popular nowadays, basically done in the neonatal unit, not by pediatric cardiologists. So many of you would at some point of time want to learn functional echocardiography. And this is a classic clinical scenario where we would like to evaluate a patient, premature baby who has a patent ductus arteriosus, look at the echo, look if treatment is necessary. Is it a large patent ductus arteriosus, a moderate size or small? That is something which you might have to learn in your future careers. So at this point of time, at 32 weeks, we would definitely like to try a medical treatment and then go on to surgical ligation if that is not possible. Here is a 1-year-old child, stable, evaluated again for the so-called recurrent upper respiratory tract infection. You hear a classical continuous murmur of a patent ductus arteriosus. On echo, you show a PDA, left to right shunt. A peak gradient of 78 usually means that the pulmonary artery pressure is normal. What would you do? Would you indicate, send this child for closure of the patent ductus arteriosus? Yes. You would like to send this patient. Why? Is the PDA likely to close? Never. Especially if it has been a mature baby. Even in a premature baby, the maximum likelihood that the child PDA might close is up to 3 months of age. That's called the delayed closure of the ductus arteriosus. But in a mature baby, you would expect that the PDA would have closed by about 48 to 72 hours of birth. And once at 1 year of age, if you're hearing a continuous murmur, this PDA is never going to close. This is very different from a ventricular septal defect and an atrial septal defect. So PDAs are not going to close at 1 year of age. So usually you would like to advise closure. Yes, please.
So like if we have a case, we have a 28, 29 weeker and somehow we detect a PDA at around 24, 25 days of life. And he is symptomatic in the form of that he is having oxygen requirement. So what is to be done?
Once about a month is over, the child is unlikely to respond to indomethacin. So you would like to advise closure. But again, it depends upon the symptomatic status. Is the child dependent on a ventilator? Is the child in heart failure? Depending on that. Because sometimes you might know, sometimes what happens is the PDA reduces in size. The child has a continuous murmur or it has a murmur, but the child is not in heart failure, not dependent on medication, then we might likely to wait and see if further spontaneous reduction in size occurs.
So then, till how long can we use indomethacin and brufen? Till what?
Probably for a week or 2 weeks, not beyond that, when it is likely to be responsive. So preterm with PDA and congestive heart failure, try indomethacin or ibuprofen, decongestive treatment, if not stable, early surgical ligation. Large PDA with congestive heart failure at any age, early closure, like a ventricular septal defect. Any audible PDA with continuous murmur should be closed electively. So the question now is, we have dealt with 3 shunt lesions, AST, VST, PDA. What is our greatest fear of untreated VST and PDA, which is large in size? Remember that one of the most common cause of death in these group of children is early death due to congestive heart failure. Second, development of pulmonary vascular disease, which is one of the most feared complications. And remember that we have now enough proof that pulmonary vascular disease starts as early as 6 months of age. If you look at autopsy specimens and microscopic examination, this is something that we have learned over a period of time. Initially, we used to wait and think that, VSD would close. But today, pulmonary vascular disease is known to develop as early as 6 months of age, and that's why we are extremely aggressive in trying to close these ventricular septal defect early in life. Fatal lower respiratory tract infections can occur in patients with large shunts. Especially winter months are extremely bad for these babies. Remember that AST has a benign natural history. In the first decade of life, pulmonary vascular disease is extremely rare. So one can actually wait and watch on atrial septal defects if you want to do so. Pulmonary vascular disease, which is the most feared complication, doesn't occur, very rarely occurs in these group of patients. And of course, heart failure is extremely rare in the first and second decade of life. I come to the next case scenario, a 3-day-old neonate, cyanosis, the systemic oxygen saturation is 60%, good peripheral pulses, the chest X-ray is normal. What would be your plan? Would you immediately intubate this child? Would you start prostaglandin infusion and ask for an echo, or wait for an echo before starting prostaglandin infusion? Very correct. The child is extremely stable. There is no need to rush in. If you have access to echo, we would like to do that. But if you don't have access to echo, then I think the second answer would be correct. The reason why I have put intubation is we have frequently had calls from various centers saying that, oh, I noticed that the child had a 60% saturation, so I immediately intubated it. Remember that these babies, or some of these babies with cyanotic heart disease, are able to tolerate very low saturations. Unlike a child who has respiratory disease causing very low saturation, these babies are extremely sick. So please do not rush into intubation. You can see that these children are tolerating this low levels of oxygen saturations very well. Because if you intubate them in a country like ours, transport, etc., becomes a big issue. Even within big metropolitan cities, that is a big issue, because they'll say we don't have an ambulance. We say that we don't have an ambulance. We don't have an incubator to transfer the child. We don't have a ventilator. So if you are sure that clinically the child is stable, do not try to intubate immediately. So you would wait for an echo to start prostaglandin infusion, but if you can't get an easy echo access, then start prostaglandin infusion and then ask for an echo. The echo shows complete transposition of great vessels with an intact ventricular septum. What would be your plan? Of course, immediately refer to a tertiary center. What we would do is maintain fluid electrolyte imbalance, maintain temperature, start prostaglandin infusion, and transfer to a pediatric center. What we would do at our level is try to do an immediate balloon septostomy and prepare the child for what is known as an early arterial switch, which we would do in the first 1 week to 10 days of life. A 20-day-old child with bile cyanosis, feeding difficulty, tachycardia, respiratory distress, normal pulses. So this is a different group of child. This patient has transposition of great vessels with ventricular septal defect or complex congenital heart disease. At your level, you would like to do decongestive treatment. At our level, we would go for an immediate surgical correction in the first 1 month of life. So these are complex congenital heart disease, feeding difficulty, tachycardia, respiratory distress, normal pulses. They are in heart failure. So there is no problem, there is no point in waiting and trying to treat them. Remember that these children's natural history is slightly different from that of patients who have just ventricular septal defect and not transposition with ventricular septal defect. They develop pulmonary vascular disease much earlier, and they are much sicker, and they tend to die much earlier in life if you don't treat them. So there would be a group of patients who are in heart failure without cyanosis and a group of patients with heart failure with cyanosis. The group of patients with heart failure and cyanosis are the ones with complex heart disease like TGA, TAPVC, single ventricle, truncus arteriosus, etc. Here, we don't even wait for 6 months of age. We would try to treat them in the first 4 weeks of life itself. Why? Because they are much more sicker. They tend to develop pulmonary vascular obstructive disease much earlier in life. So do not wait on them, do not sit on them, and hope that congestive heart failure treatment and hope that it will regress, or hope that this VSD would close, etc. Nothing of this sort is going to happen in these group of patients. The next patient is a child with 2-day-old child with severe respiratory distress. So here is a difference. The child is cyanotic, but with severe respiratory distress. Remember that this cannot be transposition of great vessel or tetralogy of Fallot, because they are a different subset of patients. They are cyanosed, but with severe respiratory distress. They have no cardiomegaly, and the X-ray shows a white lung. What do you think that this child is suffering from? Pardon? Pardon? Okay, remember that hypoplastic left heart are not cyanotic. They don't fall under the category of cyanotic heart disease. Cyanosis, no cardiac enlargement. I'm giving you a clue. The X-ray shows a white lung and this child is in severe respiratory distress. Yes, for you it is HMD, but for me, absolutely right, absolutely right. Perfect, excellent. So these are the two differential diagnoses, HMD and what we call as obstructed total anomalous pulmonary venous connection. Whenever you look at an X-ray which is suggestive of an HMD, please try to rule out obstructed total anomalous pulmonary venous connection. The X-ray shows, the echo shows obstructed TA-PVC. Management, would you give prostaglandin? Yes or no? No, because there is really no role for prostaglandin in this group of patients. There was a lot of discussions amongst the pediatric community, pediatric cardiology community. You don't have a diagnosis at the peripheral level. So you don't know whether this is obstructed TA-PVC. So what do you do? The child is in severe respiratory distress, cyanosis. Would you like to start prostaglandin at a peripheral level? The answer to this was very confusing. One, remember that prostaglandin does not cause any harm. So if you are at a very peripheral level and you start prostaglandin, we are not going to blame you as to why you did that, because you don't have an echo diagnosis. But remember that prostaglandin is going to make no difference to these group of patients. There was a discussion that some of these patients might actually worsen because you're opening the duct, you're making it more wide, and therefore you're contributing to more pulmonary blood flow, etc., etc. So these were some discussions, but overall the consensus reached was, if you have an echo diagnosis of TA-PVC obstructed and you want to transfer the baby, there is no role for prostaglandin. But if you don't have the echo diagnosis, then of course we cannot fault you for starting prostaglandin in these group of patients. And this is what the X-ray looks like. It looks exactly what you would like to see in a pediatric practice of an HMD, so you're not sure about what you're treating with. You want me to finish? I'll stop it. Okay. Oh, thank you. So this is what the typical picture is of total anomalous. Once you see this X-ray, remember that this cannot be tetralogy, this cannot be any shunt lesion. It has to be some condition which is causing severe pulmonary venous hypertension, and that is obstructed total anomalous pulmonary venous connection. So when you see total anomalous pulmonary venous connection, if you see obstructed TA-PVC, it has to be what we call as emergency surgery. When an obstructed TA-PVC reaches us at a tertiary level center where surgery is available, they usually have surgery within 3 to 4 hours after whatever preparations are necessary for a surgical correction. We do not wait on them, and they do excellently well after surgical correction. If you see non-obstructed total anomalous pulmonary venous connection who are relatively less symptomatic, not in respiratory distress, but at the same time having features of heart failure, then surgery is recommended as early as possible, but not on an emergent situation. Finally, a 6-month-old child with cyanotic spells. Treatment plan. Would you like to know the anatomical diagnosis? If your cyanotic spell is a clinical diagnosis, remember. It's not an anatomical diagnosis. Would you like to know the anatomical diagnosis or not? I think I've already given the answer here. No, we are not very interested in the anatomical diagnosis at that point of time. Remember that cyanotic spell is not caused only by tetralogy of Fallot. Any condition which causes severe reduction in pulmonary blood flow. It could be pulmonary atresia, it could be complex congenital heart diseases like tricuspid atresia, etc., which can cause a cyanotic spell. But the most common cause is, of course, tetralogy of Fallot. So once you are sure of your clinical diagnosis, that this distress, severe cyanosis, and this thing is definitely spell and not any sort of pulmonary infection or chest infection, please do not wait for any echo diagnosis. Go ahead and treat this condition. We are all aware of it. You must have read in textbook treatment of precipitating factors. One of the most common cause in our country is chest infection, and of course the child is frequently anemic. So if you can do that, correct the anemia, put the knee chest position. Hydration is a very, very important factor in these group of patients. Please give them a lot of volumes that can itself take care of the situation many times. Morphine is a very important addition because it tends to sedate the child and keep it quiet. One of the most important things of treatment of spells is try to treat the spell in presence of the mother. Let the mother keep the child in the lap. There is no need to push in oxygen, put the child in an oxygen mask or try to put nasal prongs into the child and try to give oxygen, because many times this makes the child more uncomfortable and actually it creates a vicious circle. So the most important thing in trying to treat a spell is try to quieten the child as quickly as possible. And that is where keeping the child in the mother's lap, trying to make it comfortable with the mother, trying to give morphine can sometimes just cut off the spell immediately. Then of course you have this hydration, beta blocker. Many times what one tends to do is try to find out what the blood gas is. Is it showing acidosis? So you try to put in arterial lines, etc. That is almost never necessary. Of course, there would be extreme conditions when we have spell, when we have to intubate the child to do that. But these are extremely rare clinical scenarios. Most of them are corrected with easy medications which is available. This is a classic X-ray. All that you need before you actually start going in treatment is try to get an X-ray done like this. This is a classic X-ray of a patient with reduced pulmonary blood flow. This could be tetralogy, this could be pulmonary atresia, this could be tricuspid atresia, doesn't matter. The structural defect is not important. If you look at this, you hardly see any vessels in the periphery of the lungs. It's completely absent, as if there are no vessels at all. The dark lung fields, no heart enlargement. Of course, this is a classic tetralogy, the classic bush-shaped heart that you are aware of, which you read in the textbook. But that's not important. Look at the lung fields, there are hardly any vessels seen. Finally, a 3-year-old child with mild central cyanosis, no congestive heart failure, the echo shows tetralogy of fallow with adequate anatomy. What would you do? Would you put this child on beta blockers and say that wait for 3-4 years till the child is 10 years old and then we would correct the abnormality? Would you refer the child to a pediatric cardiologist for more detailed evaluation and surgical correction? What? Would you wait? Surgical correction. Very good. There is no point in waiting. Because today, tetralogy of fallow is corrected before 1 year of age. As soon as the child is about 7 or 8 kilos, we would refer for surgical correction. Do not wait. Only yesterday, we had a 3-year-old child who about a year ago, when they came to us, was advised surgical correction of tetralogy of fallow. They came to us yesterday with a paralytic attack on the right side of the body. They did a CT scan and showed a hypoxic infarct. So please do not wait on a tetralogy of fallow child. As soon as the child is about a year old or 7 to 8 kilos in weight, go ahead and advise surgical correction, because today in tertiary centers which takes care of surgical corrections of congenital heart disease, the risk of correction of tetralogy of fallow is less than about 5%. It's almost reached 2% in major centers which cater to children with congenital heart disease. Otherwise, you will see these catastrophic events, brain abscess, hypoxic infarct, which completely maims the child for the rest of the life in a condition which is so easily treatable. So timing of surgery, a neonate who comes to you with tetralogy of fallow with severe cyanosis, you would like to do a BT shunt, that is a Blalock-Taussig shunt. If the tetralogy is stable, then total correction between 6 months to 1 year. Tetralogy of fallow with recurrent spells, we would like to give beta blockers initially, correct anemia. If the child is less than 3 months, do a BT shunt, but beyond that, beyond 6 months of age, do a complete correction if the anatomy is adequate. Do I have time or do I stop? Stop? Thank you. There is only one, I would like to show you, one echo, which is a very important thing. A 3-year-old child with fast ventricular rate, you would frequently see this in clinical practice. Heart rate is 280, poor perfusion, irritable. The ECG shows a narrow QRS tachycardia. This is the ECG at the left-hand side of the screen. What would you do? Oh, You guys are all pediatric cardiologists already. So yes, definitely, very good. You would like to give a drug option first. If that is not effective, then cardioversion. So adenosine, cardioversion, and then go on to beta blockers and then more toxic drugs which are generally not necessary. You would like to get an echo done at some point of time to rule out structural heart disease. What is the domiciliary treatment that you can give to this child? You were pointing something like this. Never do that, you know. I saw you doing this. Never ever do that because that can be very harmful. So out of these two, which one would you like? Ice pack or carotid massage? Ice pack. Carotid massage is very difficult in children, but please never do that. You know? So carotid massage, ice pack, sometimes one tends to induce vomiting or nausea and vomiting. That's a very unpleasant thing to do. So you would not like to do that. Remember that supraventricular tachycardias are very easily tolerated in children. They very rarely ever go into shock or any sort of a thing. So cardioversion is very rarely necessary. You have enough time to transport the child to a pediatric unit which has access to the availability of adenosine. The commonest mechanism of supraventricular tachycardia, in 75% of cases, it is a bypass tract, what is commonly known as WPW syndrome or pre-excitation syndrome. The classical drugs which are used are adenosine, beta blockers, calcium channel blockers. Remember that calcium channel blockers are very rarely used in children. We would advise not to use because of certain toxic effects. In the majority of cases, it will break the tachycardia. There are some rare causes of tachycardia like automatic tachycardias as it is called, which shows poor response to these above drugs, that is adenosine, beta blockers, even poor response to cardioversion. And there you require drugs to gradually control the heart rate, drugs like Codron, etc., which are much more toxic. But fortunately, it forms a very small subgroup of patients. And as far as follow-up treatment is concerned, if the child is beyond 10 years of age, there is really no role for beta blockers or any drugs. The treatment of choice to prevent further episodes is what we call as radiofrequency ablation, because this is curative. But less than 10 years of age, we would like to put the child on beta blockers, etc., drugs, etc., because there is a chance that this can regress spontaneously over a period of time. But beyond 10 years of age, there is really no point in waiting. Go for the curative treatment, which today consists of radiofrequency ablation by catheter techniques. Thank you, and sorry for engaging.
Thank you, sir. That was very, very educative, and thank you for the crisp messages that you gave for all the syndromes. Could I ask Dr. Bajaj, please, to come and honor Dr. Radhakrishnan with a memento? We have a small announcement. All the PGs and residents who are presenting posters need to be with their posters between 12 noon and 2 p.m. as that is the time when they will be judged. So they need to be with their posters between 12 noon and 2 p.m. For the next session on a neurological case, we have Professor Aneja. She's Director Professor and Head of Department of Pediatrics at Kalavati 7 Children's Hospital and Associated Lady Harding Medical College. And she is one of the pioneers of pediatric neurology as a subspecialty in India. Ma'am, please.
Well, I would like to find out how many of this is supposed to be a PG session. All of them are PGs and they're DNB PGs. Mostly are DNB or MD PGs? How many are DNB PGs? Okay, mostly they are DNB PGs. Why I'm asking is that there is a special format in DNB exam that you have one neuro case and one, often you have a neuro case. That is why people are most interested in having that anyway. So usually when you have these cases, you have some typical cases. And how many of you have already done the exam? Anybody has given the exam or all fresh they are going for exam? Huh? No, I'm just wanting to know because what is the difficulty? I was a little, ambivalent about how many cases I should take and how much, but I then thought that I'll take 2 cases for you because what happens is when you have exams, what is the patient, which is not the most common variety, but whatever is there in the wards is presented, is given to you in the hospital.